Welcome to Facebook Live here at CGH. I'm Dr. Bill Bird. I'm the Chief Medical Officer here at CGH Medical Center. Glad to be here. I think last week we had our CEO, Dr. Steinke, was here. No, he wasn't. Oh, never mind. Moving on. Hey, hi. Hey, I have Sherry DeWalt with me today. Sherry's part of our foundation. Sherry, you want to kind of say a few things about today's broadcast and maybe upcoming broadcasts?
Sure. I'm Sherry DeWalt with the CGH Health Foundation. I'm the Healthy Lifestyles Coordinator, and one of the things I do is coordinate our monthly Growing Healthier programs. And of course, we haven't been able to have those live programs, so Dr. Bird was kind enough to let us co-opt his his weekly Facebook Live. And so today's one of those days where our scheduled speaker for this month was Mary Martin. We should call her Dr. Mary, actually. And she is going to talk about some new technology with hearing aids. And I want to let you know what's coming up. So next Thursday on September 3rd at 12 noon, we will be kicking off our kind of Delicious Designs women's health issues and talking about a campaign to raise money for 3D tomography. And that's going to be at 12 noon on September 3rd. We have Gina Grennan, Dr. Corrigan, and Erica coming to talk to us then. And then in upcoming months for September, Conscious Sitter is the Growing Healthier speaker for September. I don't think we have the date scheduled yet. We're working on the date.
Still trying to finalize
that. Yeah. So watch our Facebook page and you'll see the date for Concha. In October, we will kick off Women's Health Month with Dr. McGlone, and that's going to be October 1st at 12:30 here on Facebook Live. And then in November, our Growing Healthier program will be Dr. Blasquez talking about diabetes, and that will be a great topic because people with diabetes during this COVID crisis are at risk for worse outcomes. And in case you have missed any of our past programs, including these Facebook Live ones, all of the programs are recorded and available for viewing at the CGH website, so you can go back and look at any that you haven't seen. And with that, I'm going to turn it back over to Dr. Bird and
thanks, Sherry.
Let Mary come in.
Yeah, hours of viewing pleasure for you, if you so choose. Yeah, we're going to switch out chairs there. And there she is. Hi, Mary.
Hello.
Welcome.
Thank you.
Yeah.
It's good to be here.
Yeah, glad to have you. And so for those of you who are kind of tune into us, we're going to try our best to kind of do as many of these as on Thursdays as we can, just so it kind of gives a little more rhythm to it for you to know. Not always, I can't guarantee always, because sometimes the people that I interview, or even my schedule doesn't allow that, but by and large, we're going to try to move in that direction. So yeah, here we are, August 27th. Yeah, we're solid 6 months into all this stuff. And as always, please feel free to send your questions to us, particularly if you have questions about hearing. Kind of do it sooner rather than later, because I'll be talking with Mary here for however long we talk, and then I'm going to let Mary go back to do work. And so I'll finish up with some of those COVID-specific questions towards the end. So, Mary, kind of, for those of you, I wanted to start with just the whole idea of an audiologist. Some of us have some concept of what that is. Can you kind of, to the folks who are listening, what exactly is an audiologist?
Well, audiology is the study of hearing. So an audiologist is one that would measure and diagnose hearing loss. And we work with hearing testing. We do hearing loss prevention in the industries. We do balance testing and balance exercises with patients who are dizzy. We work with hearing aids for those that have hearing loss that is not a medical treatable condition. And then we also work very closely with ENTs to help them treat hearing losses that occur in patients that have medically treatable conditions such as fluid in the middle ear, behind the eardrum, holes in the eardrum, all kinds of different conditions that then the physicians can treat.
You know, when I was a little kid, I had tubes and tonsils and all that good stuff, and I can remember sitting in the booth, and you kind of, can you hear? Can you hear? All that kind of stuff. So, you know, I think of audiology, I remember those times. How much of your time would you say, percentage-wise, just ballpark, is hearing aids? And how much of it is this other stuff that you're talking about?
Probably 30 or 40% is hearing aid work.
Really? See, and I in my mind, I had that flipped. I had it more like, okay.
Yeah, there's a lot of hearing aids. A lot of people can benefit from hearing aids.
Yeah, but I'm just surprised that 70% of people have something else. Yeah, okay. And kind of just talk through for the folks who are listening, like if they have an interest or know someone who may have an interest as they listen to this, how long does it take to become an audiologist?
It is a doctorate degree, so it's a 6 to 7 year commitment in college. The doctorate degree is in clinical audiology rather than a PhD audiologist is a research audiologist. So a PhD would do research and do work in the universities, would be, you know, professor in the universities, where an AUD audiologist is more of a clinical, is definitely a clinical person who is in the clinic working directly with patients.
So I'm like, I know in physical therapy, occupational therapy now, you know, traditionally you've done 4 years of undergrad in some degree, and then you go 2 to 3 years beyond that to get your physical therapy or whatever. But they've kind of transitioned now, and there are some schools where you can start your freshman year and go all the way through and get done a little sooner.
Yes.
You are, is that the same?
Same as audiology, yes.
Okay, all right.
Yeah. It started out where you get your bachelor's degree, then you get your master's degree, and then you get your AUD degree. But they've redesigned all the programming so that you start out knowing that you're gonna get your AUD, and so they've kind of streamlined the process a little bit.
Yeah. So basically, for someone who's interested in that, you're talking 6 to 7 years.
Yes.
Okay. All right. That's some schooling.
Yeah.
All right. You know, you mentioned this already, Mary, but just tell me a little bit more about how you kind of work hand in hand with Dr. Kempker. Dr. Kempker is our ear, nose, and throat doctor here at CGH and does a really good job. But would you kind of talk a little bit more about how you guys work together?
Sure. Yeah, Dr. Kempker is an ENT, so he will see patients, and if the patient has a complaint of ear pain, ear infection, anything with the ear, or if Dr. Kempker looks into the ear and sees that it's not a normal ear, he orders a hearing test. So any complaints about hearing loss, tinnitus, that is ringing of the ears, or anything that he sees that's not right physically, he'll order hearing testing, and then we do a lot of their patients. Dr. Kempker, and then he has a nurse practitioner also, Stephanie Ernst, in that office, and so we work with both of them.
Yeah. Hearing aids is probably one of the ones that people think of with audiology. Can you kind of just talk through, for the folks listening, the process of what the process is like for someone to be evaluated by you, to go through whatever they have to go through from an insurance standpoint, to the point they actually are putting something in their ears, and then whatever follow-up they have with you for that whole process?
Actually, I brought some models of hearing aids, but
nice.
Once someone feels like they're not hearing well, or they're referred in because they're not hearing well, or even Dr. Kempker's patients that are seeing him because they don't hear well, or they have ringing in their ears, then we'll do a hearing evaluation. And we use sound-treated room to evaluate patients and test them listening to tones, listening to speech, and listening to speech in noise to see, where exactly their hearing loss is. And then we can decide whether they qualify or, if they need hearing aids. A lot of people will just have a little bit of hearing loss, and so they can pretty well get by without, they don't need to have hearing aids. But once you have a significant amount of hearing loss, the hearing aids are very, very helpful. And we have like the in-ear styles they're still out there. In fact, the newest thing with the in-ear styles is that now they've just come out with the Bluetooth compatibility, so you can connect your hearing aids right into your computer or any Bluetooth device, your TV, computer, and most importantly, your phone.
Yeah. That's great.
And then the over-the-ear styles, now they've made them very slimmed down. There's a very transparent little tube on there that just kind of hides into your hair and skin color, and they come in lots of different colors, and those also are Bluetooth compatible. So that's really a nice feature on them. The over-the-ear hearing aids also have they're also rechargeable, so you don't fiddle with batteries anymore. You just put them in your charger at the end of the day.
Oh, nice.
They charge up, and each day you have a fresh battery.
No, that's great.
Yeah.
That sounds slick.
Mm-hmm.
Yeah. How about the insurance side of this? So, I know there's tons of different insurances between your Medicare, Medicaids, private insurance.
Mm-hmm.
Okay, most of the folks I would think are getting hearing aids are probably more that Medicare-ish age. Yes.
Yes. Yeah.
Okay.
The majority.
So,
Mhm.
like, if you were at Medicare or Medicare Advantage, just in ballpark, is it hard to get insurance coverage for that? And how long does it typically take from when they see you to when they will have hearing aids that they're using?
Well, Medicare does not pay for hearing aids.
Okay.
They don't pay a thing on hearing aids. Now, some people do have the Medicare, the Advantage U supplement to Medicare, and in that case, they will send you to a different provider for that type of, for those fittings. So, and out here, that can be really difficult because then you have to go into the Chicago suburbs,
Okay.
and a lot of people don't want to do that, so.
Wow. Yeah, so if you're
that's-
Medicare,
yeah.
gosh, for some reason or another, I don't remember that from, but yeah, so if you're Medicare, you're writing your own check for those.
Yes.
What do they run?
Mhm. You can get hearing aids for a pair of hearing aids can start out at $2,000, and then they can go up to $5,600.
Okay.
So there's a wide range of products. We try to fit the right person or the right hearing aid to each individual person. So if you're somebody who's at home most of the time, watching the ball game in the afternoon or the evening, and has family over once in a while, you don't need as many features as you do if you're in a boardroom or you're working and have to hear detailed things. So that person is gonna have to spend a little bit more to get that better quality sound.
Yeah, good. I don't know if you've experienced this, Mary, what you and your patients and stuff, but I know for myself, when one of my things with patients was, I definitely would have some folks who'd be like, I don't want hearing aids. I don't want hearing aids.
Yeah.
And I get it, and I know the expense is real.
Mm-hmm.
What I also, though, have noticed is that it seems like if you need hearing aids and don't go down the path of getting them when you need them, then number one, they don't, like that extra amplification really throws people off because they went from like nothing to the amplification. And the second thing that I see is that the longer you wait, the more like older you get in the sense that like if you're you're not picking up on all the little nuances in a room, and you're not hearing well, when you're interacting with folks, you begin to kind of, your world gets a little bit smaller and smaller. And I think that not hearing well can literally, if it may not age you, but it makes you seem older. I don't know, that's just my perspective on that. What would you say about that, Mary?
Yeah, I would agree with that. And not hearing isolates you from socialization. I mean, from other people. That differentiates, hearing loss as being a really difficult, I don't want to say disability, but a really difficult place to be, because it isolates you, and it can lead to depression, and it can get really bad for a lot of people. So it is important to get the hearing aids and be able to hear better, correct that hearing loss, whether that's through the medicine or through the hearing aids. The other thing is that the younger you are, the easier it is to learn how to use them. Your brain will adapt to hearing that sound after a while, but you're right, when you go from not hearing and then all of a sudden you can hear your watch tick, or you can hear little clicking noises in your house, that can be really overwhelming to a lot of people. So the younger you are, the easier that adaptation is, and so it is better to start out as soon as you notice having difficulties.
Yeah. So I know you're not a futurist, Mary, but as you read the trade journals in audiology, what are some things that you see as the future of folks who let's just say the hearing aid, for instance. What do you see as the future of that?
Well, first of all, as the technology has taken off with the phone, think of the very first phones that were out there that were mobile phones, and as they have gotten better and better and better, so have hearing aids, because a lot of the technology is the same thing. So they have gotten better and better and better for hearing and noise particularly, because that is really handicapping for someone with a hearing loss. So hearing and noise, and then the Bluetooth and the directional microphones and the rechargeables, those have been a big boom recently. Now the next generation of things will be not having to tap your ear for your Bluetooth, that it will come on directly. It would come on automatically. Right now you have to either push a button or you tap on your ear. So that will be there. And then there is a company working on, with the hearing aids, working on a hearing aid that will also record like your blood pressure and your, and I don't know, your heart rate, I guess, so that you could keep track of that if you're an athlete, or if you have high blood pressure and you need to keep track of that. Hearing aids will do that. So you'll have to be able to download that onto your phone or your watch, and
Sure.
it'll do that. Also, there's a company working on having a translator program, so that if you are talking with somebody in a foreign language, the hearing aid will convert it to English or whatever language, and
Nice.
yeah,
Nice.
so you'll be able to understand.
Okay.
So those are some of the things that are in the future.
Yeah. Yeah. Wow. That sounds really interesting. I can even see, like, even if you don't have hearing loss, if you're in some sort of like corporate setting or something like that, where you might want to have a hearing aid that converts the language so that you can have a conversation with someone more easily. Okay.
Yeah.
I mean, I know they have apps on the phone now where you do that, but just to have something that's pretty seamless that's in there. And
Yeah, right in your ear.
Yeah. Yeah. Okay. That's the latest and greatest for sure. Oh, you heard it from Mary. So, if you're a ringer, all right. So if you have ringing in your ears,
Mhm.
Is that like always a sign of hearing loss, or what's the deal on that, Mary?
It's not always, but it most often is a sign of hearing loss, so that needs to be looked at. You need to see your physicians for that, or come here, have a hearing test. But it can also be a sign of high blood pressure. Ototoxic medications can give you ringing in the ears. It can be like a precursor to hearing loss. It could also lead to, or help you diagnose a tumor. So there are lots of different medical problems that will create ringing in the ears. But very often it is just from the hearing loss, that the inner hair fibers of the inner part of the ear that are microscopic are damaged, which is what the hearing loss is. And because of that, the damage, they're sending little signals out that people can perceive. And we don't have a cure for that. We just have suggestions that you decrease caffeine, sugar, salt in your diet, stay off aspirin, and cover it up. And the way you cover it up is correct the hearing loss that you might have with hearing aids, so you'll hear your environment more than your own head noise. You can also cover it up by just never being in a really quiet room. So just, your TV, radio, sound machine, things like that will help cover that up. So you have something else to listen to and not just your own noise.
Yeah. I'm a bit of a ringer myself.
So am I.
So, yeah, so I'm of that age, yeah. So, yeah, I have a feeling one of these years, all my lawn mowing as a kid will, you just mowed the grass, and I remember one summer I had a job. My job was to mow a cemetery.
Oh, goodness.
Yeah, well, that's just, you had just hours and hours, you're just going, and so anyhow, that's how it is. Can't change it, but yeah, the ringing. So, follow up to that, Mary. Is there a way, short of seeing your doctor, when you would say, man, this hearing loss is a sign of something much bigger than just I've been around lawnmowers or farm equipment or whatever too much. Is there a way as a layperson to know this is more than that, and I need to see my doctor right away?
Just like little signs that you can detect on your own would be, yes, ringing in the ears is definitely something that should be looked at, because it can be something more serious than just ringing in the ears. So that should be flagged. Other things might be you're having to have people repeat, you're just not following the conversation, so you have to have what. The TV volume is a really good indicator for a lot of people, because there's a number you can look at and you can say, well, I used to listen at 16, now I'm up to 40. Or my spouse likes it at this number and I have to have it up here. So that variation is a reason to come in for a hearing test.
Okay, good. And like, you mentioned that part of your work is also just prevention. So, what are the key things that folks can do to try to prevent further hearing loss, or prevent it just to begin with?
Well, protecting your ears will prevent hearing loss. Protecting them from infection. When you have an ear infection or drainage from the ear, have it looked at and get it taken care of right away. Do not let that sit and fester and go on for any length of time. The other thing is protecting your hearing from noise exposure or extremely loud sound for a long period of time. It can, it'll wear down that ear faster than your age will. So you want to protect it with ear protection, plugs and muffs. And then medications can also lead to hearing loss, so you want to be careful about those. Quinine isn't used too much around here, but aspirin, large doses of aspirin, and then some chemotherapy agents can also cause hearing loss. So you just want to report the ringing that occurs usually before you have a hearing loss, so that you can adjust the dosage and prevent the hearing loss.
Yeah, good. What's the favorite part of your job, Mary?
The people that you meet, everyone is just unique and different, and the patients, they're really grateful. They're for the most part, we always have the grumpy ones, but most of the people are just really interesting, and you learn a lot about a lot of different things just fitting hearing aids.
Yeah. So so those soundproof booths.
Mhm.
Like if you need to get away from the world, is that where you go? Is that your happy spot, Mary?
Yeah. It's also a really good place when there's construction.
Yeah, right.
You go in there and you don't hear it.
I didn't know if you probably don't, because it's a patient area, but you probably don't take your lunch there. I'd be
Oh, that's a good idea.
I'd be inclined to take my lunch, get my little noontime siesta. I'd be ready to go
That's
for
a
the
good
afternoon.
idea. Yeah, get the Bluetooth going and.
All right, Mary, great having you.
Thank you.
I hope the folks that were listening had, I know you've learned some things about audiology that you didn't know when you showed up, and I know I have, and appreciate the work that you do. And
Call us or write us. We're on the website. If you have questions, you can get us directly, and we're
yeah,
happy
quick
to.
question about that. I'm sorry, I do have one more follow-up question.
Yeah.
So like I know that in the rehab world now, it's kind of where patients actually can go directly to their rehab doctor, to their physical therapist. Is that the case with audiology, or you need to see a doc still for that?
It just depends. It
Okay.
really depends. Medicare requires doctor's orders, so
Okay.
anyone in that Medicare age should see their physician first.
Okay.
And then.
All right, so by and large, you probably see your physician first and then kind of go from there.
Yeah.
Okay. I think over the years that may change some, but right
Yes,
now
I think
that's
it
kind of
will. Mhm.
that's where we're at right now.
Mhm.
So,
Yeah.
all right. Hey, thanks, Mary. Appreciate it.
All right,
Yeah.
thank you.
Okay, as Mary steps away, I'm trying to see what we have. Just one question that I see. The question is, will there be any drive-through vaccines scheduled by CGH? So, I think we're kind of posting that on our website, aren't we? Yeah, so you can go to our website. I feel like I would start giving details and butcher them. But I do know we have those are gonna have those on the website, and we're thinking right now of doing those probably late September, early October, kind of begin that process. And that would be one thing I would just mention here is, I know there's gonna be a big push to get flu shots this season, obviously, because you don't wanna, that makes it even more confusing for a patient who has flu-like symptoms. Is it COVID? Is it traditional influenza? So you want to try to prevent those in the first place. Here's what I've learned is that once you get the flu shot, it takes a week or two for that, for you to kind of develop the antibodies that help you to fight off the flu. And it's not a perfect shot, the flu shot, but it takes a week or two. After that, about every month thereafter, your immune response declines about 10%. So let's say you get that flu shot let's say you get it now. So if you do the math on that, that means that probably early September, your immune system's up to speed. And then every month thereafter, the flu shot loses about 10% of its effectiveness. So what I've seen in practice is that typically flu hits, and there's some variation in this, but in general, it hits sometime around, we okay? Okay. It hits sometime around November and can be as late as April. As a matter of fact, I don't know if you remember this, but when the coronavirus was first coming on board, we were still in the midst of a pretty busy flu season in March. So I say all that to say that, yeah, it makes sense, I think, for us to do the flu shots when we're doing them, to wait until around October or so to start getting your flu shots, so that the effectiveness of that shot is the best it can be for you. So just keep that in mind. I know I see signs around that talk about you can get your flu shot now and those type of things. I don't know that I would I don't think I'd be up for that. I think it'd be better to wait just a little bit before you get those. And the question was a little bit too about drive-through vaccines. I don't know if you were really talking about, we might have been talking just about the flu itself, but as far as the vaccine for COVID goes, yeah, I suspect that we will have something, and probably how it's going to go is that the first doses would go to those people at highest risk, like nursing homes, folks who are from ethnic groups that are more heavily hit by this, and of course healthcare folks as well. So that would be my guess, the first batch of folks who get these vaccinations, and then I would think, sometime after that it would be the general public that would start getting them. It's sounding like at least one of the ones that I'm tracking is that it's a two-shot process, so you get one and you get another shot. I can't remember if it was like a month later, but something like that, which is not unheard of for immunizations to have it that way. There's definitely been a lot of, I think, understandably press about, yeah, we're excited about the opportunity to have a vaccination, and yet we want to make sure that it's a good one and that it's a safe one. And yeah, personally, I'd be happy if the vaccination was available sometime after the election, because it'd make me feel better that okay, this is up to speed, this is all kosher, we want to go for this, and we want to start giving it to people. So we'll see. We'll see on that. Otherwise, as far as the COVID situation goes, we continue to have cases here at the hospital. We continue to, our rapid testing supply continues to be short, but our ability to send out labs to check for COVID is we're still doing okay as far as that goes. We continue to have patients here who are suspect COVID patients or patients who are COVID patients that we're taking care of here at the hospital. I read an article today and was talking about some of the things that are happening that are helping doctors to do a better job of helping more patients who are really sick with COVID to get through this. And if I can remember the four, one of them is that we're trying to keep more patients home because there's a lot of people that can just stay home and get through this. We're using the prone position at least once a day for really sick patients as best we can. The remdesivir, and I forget there was another drug, but I know for sure dexamethasone, which is a steroid. Using those for some of our sicker patients, it is trending like those are helpful. They are helping those patients to get through that, to get the situation through this. And then finally, early on, there was a big push of how many ventilators we were going to need and how many ventilators we were using. And that definitely has done a 180 since what's around here since March, when the pandemic really became front and center. And basically, we in the medical community try to hold off as long as we possibly can before we do put a patient on a ventilator. And the thinking is that when you do a ventilator, it artificially is pushing air into your lungs, and it affects the air exchanges to the point where if you're already kind of marginal in terms of how you're doing, it seems like it would help, but it can also hurt. So that's another thing that's definitely changed, is we'll let folks have their oxygen levels be kind of borderline or use a lot of oxygen for them to try to get them by, and they seem to do better. So those are some things on the medical side of things that I do think are improvements from 6 months ago when this whole process started. I want to make sure, I don't want to go, we're good, right? Okay, so hey, thank you for listening in. Hope you enjoyed it. Hope it was informative. We're trying to kind of add some information about just general medical stuff into this, because you can only talk about a pandemic so long, and it's like, okay, yeah, got it. So we're continuing to answer your questions about that. We're trying to add some other stuff. And speaking of that, next week, we're going to have some folks on, and we're going to talk about 3D mammography. So right now, mammography tends to be two-dimensional, and there are now we're moving in the world here where we're going to 3D mammography, and we're gonna be getting that here at CGH. And we're gonna have some folks talk about that, talk about some breast health stuff next week. So I'd encourage you to kind of show up on, I think it's noon next Thursday. We're gonna chat and talk about breast health, and we're gonna talk about 3D mammograms and some of those kind of things. So until then, have a great week. Talk to you next Thursday. Bye.